Good morning, students. Today we see regarding the various committees of India. You have learned about the health planning in India. So, health planning in India is an integral part of the national socio-economic planning. The guidelines for national health planning were provided by a number of committees dated back to Boer Committee in 1946. These committees were appointed by the Government of India from time to time to review the existing health situation and recommend measures for further action. More recently, the Alma Ata Declaration on Primary Health Care. You have learned about this Alma Ata Declaration, and the National Health Policy of the government gave a new direction to health planning in India, making primary health care the central function and main focus of its national health system. The goal of national health planning in India now is to attain health for all by the year 2000. Boer Committee was in 1946. Sir Joseph Boer was the leader of this committee. This committee, known as the Health Survey and Development Committee, was appointed in 1943 with Sir Joseph Boer as its chairman. It laid emphasis on integration of curative and preventive medicine at all levels. It made comprehensive recommendations for remodeling of health services in India. The report submitted in 1946 had some important recommendations like integration of preventive and curative services of all administrative levels. Development of primary health care centers in two stages. Short-term measure, one primary health center as suggested for a population of 40,000. Each PHC was to be manned by 2 doctors, 1 nurse, 4 public health nurses, 4 midwives, 4 trained dyes, 2 sanitary inspectors, 2 health assistants, 1 pharmacist, and 15 other class 4 employees. Secondary Health Center was also envisaged to provide support to PHC and to continue and supervise their function. Second one is a long-term program also called the 3 Million Plan of setting up primary health units with 75 bedded hospitals for each 10,000 to 20,000 population and secondary units with 650 bedded hospital, again regionalized around district hospitals with 2,500 beds. The third one is major changes in medical education, which includes 3-month training in preventive and social medicine to prepare social physicians. Next was the Mudaliar Committee in 1962. It was under the leadership of Sir A. Lakshmaswamy Mudaliar. Mudaliar Committee in 1962. This committee, known as the Health Survey and Planning Committee, headed by Dr. A. L. Mudaliar, was appointed to assess the performance in health sector since the submission of Boer Committee report. This committee found the conditions in the PHCs to be unsatisfactory and suggested that the PHC already established should be strengthened before new ones are opened. Strengthening of subdivisional and district hospitals were also envisaged. It was emphasized that a PHC should not be made to cater to more than 40,000 population and that the curative, preventive and promotive services should be all provided at the PHC. The Mudaliar Committee also recommended that an All India Health Service should be created to replace the erstwhile Indian Medical Service. Next one was the Chadha Committee in 1963. This committee was appointed under the chairmanship of Dr. M.S. Chadha, the then Director of the General of Health Services, to advise about the necessary arrangements for the maintenance phase of National Malaria Eradication Program. The committee suggested that the vigilance activity in the NMEP should be carried out by basic health workers, 1 per 10,000 population, who would function as multi-purpose workers and would perform in addition to malaria work The duties of family planning and vital statistics data collection under supervision of family planning health assistants. Next one was Mukherjee Committee in 1965. The recommendation of Chadda Committee when implemented were found to be impracticable because the basic health workers with their multiple functions could do justice neither to malaria work nor to family planning work. The Mukherjee Committee, headed by then Secretary of Health Sri Mukherjee, was appointed to review the performance in the area of family planning. The committee recommended separate staff for the family planning program. The family planning assistants were to undertake family planning duties only. The basic health workers were to be utilized for purposes other than family planning. The committee also recommended to delink the malaria activities from family planning so that the latter would receive undivided attention for its staff. Mukherjee Committee in 1966, multiple activities of the mass programs like family planning, smallpox, leprosy, trachoma, national malaria eradication program during the maintenance phase, etc., were making it difficult for the states to undertake this effectively because of the shortage of funds. A committee of state health secretaries headed by the Union Health Secretary Sri Mukherjee was set up to look into this problem. This committee worked out the details of the basic health service which should be provided at the block level and some consequential strengthening required at higher levels of administration. Next one was the Jangalwala Committee 1967 by Dr. Naushir Jangalwala. It was under the leadership of this doctor. Jangalwala Committee in 1967, known as the Committee on Integration of Health Services, was set up in 1964 under the chairmanship of Dr. N. Jangalwala, the then Director of National Institute of Health Administration and Education, currently NIHFW. It was asked to look into various problems related to integration of health services, abolition of private practice by doctors in government services, and the service condition of doctors. The committee defined integrated health services as a service with unified approach for all problems instead of a segmented approach for different problems. By medical care and healthcare programs should be put under charge of a single administrator at all levels of hierarchy. Following steps were recommended for the integration at all levels of health organization in the country: unified cadre, common seniority, recognition of extra qualifications, equal pay for equal work, special pay for special work, abolition of private practice by government doctors, improvement in their service conditions. Various categories of peripheral workers should be amalgamated into a single cadre of multipurpose workers, male and female. Thus, while auxiliary nurse midwives were to be converted into multipurpose workers, female, and the basic health workers, malaria surveillance workers, etc., were to be converted to multipurpose workers, male. The worker of 3 to 4 male and female multipurpose workers was to be supervised by one health supervisor, male or female respectively. The existing lady health visitors were to be converted into female health supervisors. One primary health center should cover a population of 50,000. It should be divided into 6 sub-centers, one for 3,000 to 3,500 population, each to be staffed by a male and female health worker. Next one was the Srivastav Committee in 1975. This committee was set up in 1974 as Group on Medical Education and Support Manpower to determine steps needed to reorient medical education in accordance with national needs and priorities. Develop a curriculum for health assistants who were to function as a link between the medical officers and multipurpose workers. It recommended immediate action for creation of bonds of paraprofessional and semi-professional health workers from within the community itself. Establishment of 3 cadres of health workers, namely multipurpose health workers and health assistants between the community level workers and doctors at PHC. Development of a referral service complex, establishment of a medical and health education commission for planning and implementing the reforms needed in health and medical education on the lines of University Grants Commission. Acceptance of the recommendation of the Srivastava Committee in 1977 led to the launching of the Rural Health Service. Rural Health Scheme. In 1977, the basic recommendation of the committee were accepted by the government in 1977, which led to the launching of the Rural Health Scheme. The program of training of community health workers was initiated during 1977 to 1978. Steps were also initiated for involvement of medical colleges in the total health care of the selected PHCs with the objective of reorienting medical education to the needs of rural people. Reorienting training of multipurpose workers engaged in the control of various communicable disease programs into unipurpose workers. This plan of action was adopted by the joint meeting of the Central Council of Health and Central Family Planning Council held in New Delhi in April 1976. Health for All by 2008, a report of the working group. 1981, a working group on health was constituted by the Planning Commission in 1980 with the Secretary, Ministry of Health and Family Welfare as its chairman to outline with that perspective the specific programs for the sixth five-year plan. The working group, besides identifying and setting out the broad approach to health planning during the sixth five-year plan, has also evolved fairly specific indices and targets to be achieved in the country by 2000 AD. Thank you, dear students. The rest of it we'll see in the next video.